We know that AMR surveillance is not the same everywhere. Sometimes we lack data entirely. Sometimes we have the data, but they do not reach decision makers and practitioners at the right place and time. And what all of this ends up resulting is in a lack of action, or action and policy that is not informed by data or evidence. And I think we lately learned from the COVID pandemic that politicians need the evidence-based data. What we need, therefore, is surveillance data to inform national action plans, and simultaneously, we need to adapt plans and efforts to local context and focus on a sector-specific work. These need to be brought together in the second step, then, in an integrated and coherent way. The role of national public health institutes, I'd like to highlight this year, is absolutely essential in this task. It is on the backs of these workhorses that integrated surveillance can be effectively built as a fundamental element in tackling AMR. So, what do we want to cover in this session? First, we would like to understand the current global situation on integrated surveillance of AMR and AMU and discuss how to make global progress. Second, we want to discuss how to mobilize resources, infrastructures, and capacity, as well as which stepwise approach could be taken to strengthen integrated surveillance. And third, finally, we want to focus on the importance of using surveillance to support policy and political action. So now we'll introduce our panelists. First, however, I have to introduce the rapporteur. There she's sitting. Our rapporteur today is Dr. Yewande Alimi. If you stand up, please. She's at the WHO in the Program Coordinator of Antimicrobial Resistance and One Health Africa Centers for Disease Control and Prevention. She's also the co-lead of African Union Task Force on AMR. So our first panelist is Professor Sabia Esak. She holds a research chair in antibiotic resistance and One Health and is professor of pharmaceutical science at the University of KwaZulu-Natal. She's vice chair of the WHO Strategic and Technical Advisory Group for Antimicrobial Resistance, the STAC AMR, and serves on the advisory boards of ICARS, JPAMR, CARP-X, and the Fleming Fund. So, the second speaker will be Dr. Carolee Carson. She's the Analysis and Communication Lead of the Canadian Integrated Program for Antimicrobial Resistance Surveillance, CIPARS, at the Public Health Agency of Canada. She has lent technical expertise to quadripartite endeavors, including the Codex Guidelines for Integrated Monitoring and Surveillance of Foodborne AMR, development of the One Health Priority Research Agenda for AMR, and the WAR AMU Technical Reference Group. Our third speaker panelist will be Dr. Amina Al-Jardani. She is consultant microbiologist at the Central Public Health Laboratories and WHO Collaborating Center for Emerging and Re-emerging Infections here in Oman. She's the National Antimicrobial Resistance Focal Point, and she is also the PulseNet Middle East Network Coordinator. She's leading the work of the national reference laboratories involved in the detection of infectious agents. And last but not least, we have Professor Rungtip Chuan Chen. She's a veterinarian professor at Faculty of Veterinary Science in Chulalongkorn University. She's the head of the research unit in microbial food safety and antimicrobial resistance, the director Center for Antimicrobial Resistance in Foodborne Pathogens in cooperation with WHO, and director Global Foodborne Infections Network, Southeast Asia and Western Pacific region, and the director FAO Reference Center for Antimicrobial Resistance. She supports countries in Asia and Pacific regions to strengthen their capacities and capabilities to manage AMR risks, national AMR surveillance, data collection and analysis, and antimicrobial susceptibility testing, and quality assurance in veterinary laboratories. So obviously, we have a fantastic panel here, so I'm very much looking forward to our discussions. Now I hand over to our first speaker, which is Sabia. And because we have no podium, please allow us to step down, because this is a safety issue, not that somebody falls apart down from this podium. This would be bad.
So, distinguished guests, colleagues, ladies and gentlemen, good afternoon. And Assalamu alaikum wa rahmatullahi wa barakatuh. I'm going to speak about the what, the why, the what, and the how of integrated surveillance. So why do we need integrated surveillance? What do we mean by integrated surveillance? And how do we go about doing integrated surveillance? So let's answer the first question in terms of the why. Many of you have seen these infographics. The first one is on the epidemiology of AMR, and it goes all the way back to 1977. And it highlights the fact that AMR is, as we have often referred it, a quintessential One Health issue. Now, I want you to pay attention to the number of arrows and the multidirectionality of the arrows, which shows you that AMR exists and it's transferred between humans, animals, plants, and the environment. This is proof enough that we need integrated surveillance. The second infographic is the collective antimicrobial resistance ecosystem. And this takes a bit of a different look on this, where it looks at the ways in which we, as well as humans and animals and plants and crops, are exposed to antimicrobial resistance, as well as antimicrobial residues in different areas. So you can see that it covers everything from wildlife to wastewater sources, recreational areas, and food and feed. So this is why we need integrated surveillance. So what is integrated surveillance? And here I've drawn on the conceptual framework of TISA, which is the tripartite integrated surveillance system for AMR and AMU. This is the conceptual framework. This is been delayed a little bit because of the need to include the environmental aspect of it in terms of AMR in the environment and as well as residues within the environment. And I want to highlight here that integration can occur at 3 levels, to my mind. First of all, we have the integration of antimicrobial resistance and antimicrobial use data, and that's within the different sectors, right? So it could be in human health, animal health, plants, and in the environment. Then we have the integration and triangulation of AMR and AMU data across sectors. So this is where we bring in all of the information from the different sectors and try to make sense of it in terms of the One Health component, triangulation, transmission dynamics, risks, etc. And for me, a really important aspect is to integrate surveillance in sectors as well as collectively into our routine health systems, our routine agricultural systems, and our routine environmental health systems. So I've taken the integration definition a little bit more to say the sooner we get AMR away from being a siloed program and more integrated into our systems, the easier it will be to be able to monitor it and address the actions that are needed for it. So in the short term, we already do this in our countries. We have sector-specific sample collection, processing, analysis, and whether this is from microbial culture and sensitivity testing or whether it's from genomic surveillance. So here in this scenario, integration happens at the planning and the resourcing level at the beginning. And then at the end, when we have data analysis, triangulation, and communication. So we come in at the integration comes in at the beginning for planning and resourcing, and at the end for analysis and communication, while in the middle, the sectors work within their own sectors to generate the data. And ideally, we want to formulate a One Health surveillance a protocol that includes all of the things I've listed there: minimum sampling framework, sampling sizes, sample sources, sampling frequency, quality assured standard operating procedures for laboratory investigations, and then integrated and triangulated analysis, interpretation, and communication to inform action by policymakers as well as other stakeholders. And this is my first prize, what I would ultimately like to see in the medium to long term. So we have an electronic platform that monitors trends in antimicrobial resistance in association with antimicrobial use. And all of this data comes from, well, obviously humans, animals, plants, and the environment, but from a range of interlinked, integrated, quality assured, representative, phenotypic, and genomic surveillance system. And this really deals with the AMR, AMU, and the AMR-specific aspects. Then I want to add to this platform a number of AMR-sensitive aspects, such as governance, health expenditure, education, infrastructure, WASH, etc., that can come into it as well. And this are the AMR-sensitive parameters and also include vaccination and biosecurity. And hopefully this would serve as an early warning system for emerging or escalating AMR, pinpoint infection outbreaks, as well as areas for intervention. So how do we go about doing this? Obviously, surveillance of any kind, whether sector-specific or integrated, requires human, infrastructural, and operational resources. And while the Multi-Partner Trust Fund and the quadripartite departments individually and collectively, as well as other stakeholders such as the Fleming Fund, do fund surveillance, the funding may ultimately run out. And so how do we sustain surveillance once this external funding has ceased? And in country, we need to integrate these systems into existing surveillance systems. For example, TB, HIV, and malaria are very strong vertical programs, especially in LMICs. They have the laboratory capacity, surveillance, regulations, etc., which can be leveraged to include AMR surveillance. Then we have food safety and food security aspects and animal health and welfare programs, also a potential way of leveraging AMR surveillance. And then all countries do water quality testing, and a large number of countries have used a wastewater testing for SARS-CoV-2, which can also be leveraged for AMR. And all of this requires the 6 C's, which are consultation, collaboration, coordination, communication, and capacity building. And I want to be bold and say it also requires another C, which is compromise, because something has to be compromised for surveillance to take off the way we need for it to take off, especially in resource-constrained settings. And then the second aspect is that there are several technical guidelines, SOPs, etc., that are already available on how to undertake surveillance, whether in LMICs or in any environment. And we need the technical capacity to adapt these to local country context and to local country resources. And for this, we want implementation research. And the definition of implementation research is listed here, which is the scientific inquiry into questions concerning implementation, the act of carrying an intention into effect. So public health surveillance is the ongoing systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice. So I've taken the liberty of rewording this to think about integrated surveillance. So integrated One Health surveillance is the collaborative and continuous systematic collection, analysis, and interpretation and communication of AMR, AMU, and relevant AMR sensitive data essential for action. That is the planning, implementation, and evaluation of interventions to optimize One Health policy and practice to mitigate AMR. And all of that is covered in this conceptual framework. And I want to end by saying that AMR is no longer silent. We saw that by all of the presentations today. It is no longer a threat. It is clear and present danger. Thank you.
Thank you very much, Sabia. We will have an open Q&A after all 4 presented, but let me ask you one question, Sabia. The TISA that you showed us. So how many countries you think will have such a program already running or are establishing it?
So I think that integrated surveillance is in its infancy. A number of the European countries, the high-income countries, have already implemented things. I'm not sure that the integration has happened to the extent that it should have, but there is certainly sector-specific surveillance going on in AMR as well as AMU. And there are initiatives to look at it, especially on an analytical way amongst the sectors. So it's still the collection and the data processing, etc., still happens in individual sectors, but the analysis happens in an integrated fashion. The big prize is to really develop a specific framework that covers all sectors and allows everything from scratch, and that has to be developed. And I'm thinking that the quadripartite task team will have that as its very first task. But just to also say that while we're waiting for TISA to be implemented, the Tricycle project is something that has attempted to institute integrated surveillance in a number of countries. And the Tricycle project really speaks about the how-to. It looks at a single organism, as almost everyone in this audience will know, it's ESBL positive E. coli. And we look at it in humans, at community level and at hospital level. We're looking at it in chickens, in feed and food, and I can't remember exactly all of the the sampling sources that we use. And then the JPIMR funded a virtual network on how to improve the tricycle project. And there's some really good experiences and outputs from that project that are now going to inform the improvement of the tricycle project as well. So, yeah.
Thank you, Sabir. We will surely move in this more deeply later on. Carolee, now it's your turn.
Okay, perfect, hang on. With many thanks to the organizers, it's my pleasure to be here today to talk to you about the development of integrated surveillance of antimicrobial use and resistance using a case study from Canada. And I'll also show you how the surveillance data has been used for action. So in Canada, taking the very first step required a lot of planning and some courage. So the first thing we did is we set out what did we want to do with integrated surveillance? What were our objectives? And then we took the time to map our system. And what I mean by this is we actually had a look at how antimicrobials were coming into our country, how they were bought, how they were sold, and how they got into the hands of the end users. And then we also looked at what infrastructure we had already in place, if any. And we looked to see if that infrastructure would meet our surveillance objectives. And when it didn't, we had to consider what we needed to build. So what I'm going to show you is about the Canadian Integrated Program for Antimicrobial Resistance Surveillance, or CPARS for short. And we started CPARS in 2002. And we were designed from the beginning to be an integrated surveillance program, but what you see on the slide is where we started. We only had salmonella from humans, salmonella from sick animals. We only had 4 months of data where we collected samples from abattoirs from healthy chickens, cattle, and pigs, and we had human pharmacy sales. But we had a plan. And we kept building towards that plan. So this is us today. So we have 4 main components. We have human antimicrobial resistance. We have animal and food antimicrobial resistance. And you can see the different host species, different stages of the food chain, as well as the different bacterial species in the symbols above the host that we do surveillance on. We have antimicrobial use or sales data from people, animals, and crops. And we bring all that data together to integrate it. And as Dr. Lothar mentioned earlier, CPARS is led by the Public Health Agency of Canada, but we have input from multiple federal departments and other sectors. We also have provincial input, and we have input from the private sector and academia. And so that's when you have the data coming in and you have the infrastructure in place, what can integrated surveillance do? It can do a lot. So this slide here was in our 2003 report. And this is a story about people, chickens, Salmonella Heidelberg, which happens to be a particularly pathogenic strain of Salmonella, and resistance to a critically important antimicrobial class called the third generation cephalosporins, and use of this class in poultry. So 2003. And as a reminder, we started in 2002, so we were in our infancy and we didn't have complete geographic coverage of some of the sampling we were doing. This slide shows what we had in people and in grocery store meat, particularly chicken. And what you see in the green and darker purple line at the top was resistance to third generation cephalosporins in Salmonella Heidelberg in one province compared to the other, which is in pink. And what you'll note, resistance was higher in that one province than the other, but it was higher in retail chicken than it was in people. And we had anecdotal information at the time that there was very high level use of this third generation cephalosporin class in poultry in that province. So what happened next? We expanded our surveillance. And what you see with the horizontal lines across the screen is resistance to this third generation cephalosporin class in Salmonella Heidelberg. The data from people is in green, and what we saw in grocery store chicken is in blue. So when we released that 2003 report, it came out early 2005, and within weeks, the poultry industry in that higher province stopped the preventive use of this antimicrobial class. And what you can see is that the resistance rates both in retail chicken and in people plummeted. But over time, they went back to using that drug again on a rotational basis. And you can see those lines climb back up from about 2007 to 2014. In 2013, the poultry industry worked with us to implement farm surveillance. So this is where we collect antimicrobial use on farm as well as samples for resistance testing. So in 2013, a third of the farms were still using this antimicrobial in a disease preventive manner. In 2014, the poultry industry across all of Canada for multiple poultry sectors banned the preventive use of this antimicrobial class. So you can see the resistance rates declined in everything, including from the healthy chickens in farm, which is the red line. And the use went from 31% to 0% in our Sentinel farms. So I'm showing you this too because this is an example of a simple descriptive picture of integrated surveillance data. One of the key things is that the data have to be collected in a way that's comparable. And so just some final takeaways from our experience in Canada. Plan well and simply begin. And even if you don't have it fully integrated at the beginning, if you have a good plan, you can keep building towards that. One of the things I didn't mention is that, which was just mentioned in the previous presentation, who are your key audiences? Because surveillance is data for action. What are their needs? What are the needs of the farmers when they receive this data? How do they need to receive it? Where is harmonization built in? And what needs to be built? Sharing data and experiences is invaluable. The surveillance data are intended to be used, and it's really important to state your limitations and your data gaps, because if you have a running knowledge of what your data gaps are, should an opportunity come up, you can seize that opportunity and plug it into your system. Sometimes we were so focused on getting our surveillance data out and analyzed that we didn't always capture the uses of our data. But you need to know who's using the data, how and why, to show value of the surveillance system. And antimicrobial resistance and use is complex. You've seen the systems maps in the previous presentation. However, even simple integrated figures of findings that are comparable can lead to effective action. Thank you.
Thank you, Curly. A wonderful best practice example here. So I understand you started with Salmonella because you already had some surveillance data on Salmonella. So basically other countries could start with a totally different pathogen. That's the take-home message, that you first have to analyze the situation in a country and then you start?
I think there's two ways to look at it. In our situation where resources were scarce at the beginning, Salmonella was the only bacteria that we could integrate on at all. So it became quite a priority for us to build that into our surveillance system at different components along the food chain. However, if there's an opportunity to build it from scratch for different things that you're looking on, there might be a different pathogen that would be the target, maybe a priority in that country.
That's interesting, because this is a very important topic, no? Why do you start, how do you start? Now I hand over to my lovely co-chair, and I'm co-moderator, and I'm now out of business, basically.
Good afternoon, everybody. Thank you for the great two speakers, and thank you. You should be happy you took a look. Now the room is full. We're a bit anxious, but we need a lot of champions who can understand integrated surveillance. So I'll hand over to our next speaker, Dr. Amin Al-Jordani, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good afternoon. So from Canada to Oman, and we'll zoom down to the laboratory, the backbone of surveillance. Can I have my slides? So we all now know that integrated surveillance is essential pillar of the action plans, and the laboratories are the backbone of this surveillance. Therefore, countries and sectors should have a functional nationwide laboratory system. And they have to have an inventory of all their labs so that they can assess their resources And also, it's a forum for enhanced collaboration and information sharing. And also, of course, to identify diagnostic lab capabilities to support their surveillance system. This is going very fast. Okay, so in Oman, we started in 2013. And when we started, our laboratories were not fully standardized in terms of susceptibility testing. So we thought to go about standardization of all the testing in the country, had a guideline and workshops to train them. Of course, this was backed up by a policy signed by His Excellency at that time to support us in implementing the surveillance system in the country. In Oman, it's a collaborative work between different directorates in the health sector. So IT is there, surveillance, infection prevention control, the pharmacy for the use of the antibiotic, and the Central Public Health Lab was the reference lab for the system. And we use the electronic health system and the lab information system to gather the data from all these sources. So we started with 6 sentinel sites. So we started with small steps in the country. We couldn't do it. We have 11 governorates, but we started with 6 hospitals only. And now we have 9 sentinel sites. We started with targeting priority organisms according to the GLASS plan. And we are reporting incidents of MDRO per 100,000 population. We also report bloodstream infections and mortality rates as a surrogate of the burden of the MDROs in the country. We also produce annual AMR report, we call it OMAS, like GLASS, and national antibiogram. We also monitor the antimicrobial use in the 6 or the 9 sentinel sites now and produce a report to the hospital administrators and to the end users in the laboratories and also the clinical sites. We recently integrated our traditional way of surveillance and moved into integrating into whole genome sequencing. And this will help us in detecting novel emergence of novel resistant mechanisms or importation. And here we have an example of XDR, extensively resistant typhoid, imported from Pakistan, was proven by whole genome sequencing. This is another example of hypervirulent Klebsiella causing outbreaks in some hospitals in the country. And when we did the whole genome sequencing, it clustered with isolates from China. And the index case was non-Omani. We also participate in the GLASS platform for reporting. Initially in our plan that we have integrated surveillance for health sector as well as agriculture, animal health, and private sector. So far, we are only concentrating in the health sector because of certain challenges and limitations in the agriculture and animal side. We'll talk about those at the end of the presentation. Recently also introduced environmental AMR surveillance in the capital area in Muscat. And we included sites from hospital sites, residential areas, and one industrial site. And we were surprised with the findings. This is the collection sites. So we looked at the AMR genes, and what surprised us that the presence of AMR genes in residential wastewater was really close to the hospital. So AMR is really widely distributed in the community. And also we detected resistant genes for the last resort antibiotics like carbapenem, colistin, and fosfomycin. Moving to the regional level, so this is our national experience. At the regional level, the Central Public Health Laboratory is a coordinator for this network, PulseNet Middle East, which is part of the international PulseNet for foodborne surveillance. And in this network in our region, we have 17 countries involving labs, public health laboratories, academic, food safety labs, and we have also academic centers. And recently also they embarked into conducting whole genome sequencing for enteric pathogens. So this can be a forum for more collaboration, for assessing the burden of AMR in the region as well. We also enforce quality, and we are a provider for external quality at national level as well as regional level. We are the external quality assurance provider for 30 labs in the region, and we produce this report on annual basis. The laboratories also play a major role in training, and we do it nationally also as regionally. So I mentioned we have conducted several training on antibiotic susceptibility. We are embarking on programs for leadership in laboratories, focusing on surveillance, management, and leadership. And this is as like a multi-sectorial activity involving health, academic, food safety, agriculture, and animals, in collaboration with WHO, CDC, as well as APHL USA. Several sequencing and bioinformatics training was also conducted, not only for viruses and COVID, but also for enteric pathogens and AMR pathogens. Challenges, we have different challenges in the health sector as well as the agriculture and animal side. In the agriculture and animal side, currently it's only event-based surveillance. So whenever there is an outbreak or finding of unusual pathogens, they send it for characterization. But there is no systematic surveillance in that sector. Because of limited infrastructure, supply, trained manpower, a major problem is the loss of trained, competent professionals and high turnover of leadership. Also, there are other competing priorities, as we all know. So in conclusion, integrated surveillance is an essential pillar. We should have a functional lab system to support this surveillance, and stepwise implementation is the key, because we need to start from small steps to a bigger integrated surveillance system. Twinning and collaboration within your own sector, your own country, your region, and globally is a key for success. And of course, to do that, we need sustained funding, political support to have an effective system. Thank you very much.
Thank you. Thank you very much, and I think you've come a very long way and really a regional leader on this topic. We will be taking more questions at the end, but maybe just to follow up a little bit from your conclusions. You talked about the stepwise and how you moved forward. Do you have any tips or ideas on the specifically, again, how to start and where to start specifically with the funding and prioritization of where to go in such elaborate vision?
I guess the key is knowing your own resources in the country or in your own sector. Because when we started, we didn't have to ask for resources. The resources are there. We just have to train, standardize, and come up with a guideline and a policy. So each sector should map their own resources, and then maybe integration within the system. They can integrate into another program, for example. How did we come with a whole genome sequencing for enteric pathogen? We utilize COVID sequencing platform. We have a central facility in the laboratory, and we utilize that. So integration within the laboratory, within the sector, within the country is very important. So mapping your resources, and then if there are no resources, of course, we have to ask for those resources by getting the leaders and the political and decision maker into the support for this program.
Thank you very, very much. And there is another session specifically to tackle the issue of funding, and we hope to hear from them. Thank you very much, Dr. Jardani. And now we'll give the floor to Dr. Shun. Please, the floor is yours.
Okay, Dr. Lothar gave me just only 5 minutes. Let me negotiate. 6 minutes and 30 seconds. Okay. Okay. No, microphone is mine, so he cannot say anything. All right, then. So what I will highlight, okay, it will be the challenge, and way forward for turning the integrated AMR surveillance data into meaningful actions and policies. Okay, so I just said, let's start with the fact that not all the countries, are in the same or have the same degree of development in terms of AMR testing and surveillance capacity. So when we start, we can see that the problem is not just only how to translate the data, but it begins with how country could produce the good quality data. And as a FAO, as a FAO reference center, we have missions, to assess the capacity for AMR testing and surveillance, in animal sector in Asia Pacific. Okay, and we also provide the recommendations, to the country to allow them to identify the step for improvement, prioritize the actions, and also monitor their progress, over time. And what we found that the development level were valid. Okay, some of the country they didn't even have the national AMR surveillance in place. Okay, some of them are at the beginning of the initiations of the program, and we found the common challenges, that become the problematic issues, like most of the countries have insufficient knowledge, facility, and infrastructures, and many of them don't have inadequate human and financial resources, and also they don't have the regulations or coordination between relevant sectors. Sometimes they do have, but it's not effective or not good enough. And based on those at-large results, I think I forgot to mention that the tools that I used to assess the capacities, it was a FAO at-large, okay? And that, based on the FAO at-large results, we deliver the assistance to the country based on the results, and we provide whatever they need, okay? And we also make sure that what we provide is fit and is to strengthen and build the capacity that they really lacked, okay? And up to that, national AMR surveillance have been started in many countries, and some of them have already, started and produced the AMR data. And also some of them already even at the initiation step for integrated AMR surveillance. And, for the latter, they have the basic questions. And that basic questions is very common. Let's just start with what bacteria and antibiotics should be included, what interpretive criteria should be included. They know that the data from integrated AMR surveillance could be more useful, but many of them are still uncertain how to effectively analyze the data or how can they use it. So when we come to the questions, how can we turn the AMR data, into the meaningful actions and policy. I really like this word, meaningful. So it shows that it has a meaning, right? So in my opinion, I think the support that we should provide them, it depends, what the country, right? It should be level. For example, here, the country with no AMR, no national AMR surveillance program, we should help them to have or to establish one. And for those already have existing national AMR surveillance in its sectors, so we should support them for integrating the program across the sectors. And this could be like providing them the technical and financial support. And for those countries with the advanced one already have the integrated AMR surveillance, I think the sustainability, and the other words very hard for me to pronounce, the applicability, okay, it should be fostered to them, all right? And in my opinion, okay, I think it's the country who make decision, what are they going to do with the AMR data they have. And I have a chance to speak to two of my friends from the country that already have the integrated AMR surveillance in place. They said what they need to support is the protocol to make sure that what they have is a complete, effective, integrated AMR surveillance program. So they told me that what they want the protocol that explain, the scientific and knowledge and technical support, and they would like to have the guideline or the protocol, for the AMR data analysis, integrations, and management. And last one, they also would like to have the assessment in evaluation tools. So this is all just one to know what they have is good, okay? And, I would like to highlight this, Okay, this is an initiative, for the AMR data management for the animal health sectors that has been limited due to the lack of coordinations and harmonization within and between the sectors. And, taking off from the successful use, okay, of the HUNET in human sectors, okay, this software has been expanded to support, okay, the AMR data management, okay, from food and agricultural sectors. And I think it's called the beta version, okay? With this new version, we expect that the link, okay, between the AMR data, of the AMR data between the sector will be improved, and this will definitely increase the successfulness of integrated AMR surveillance. And I would like to end my presentation with this. Okay, I just added in the morning. Okay, so to make the integrated AMR surveillance programs sustainable and feasible. Okay, so it's important that we bring the AMR to national priority and put the AMR issue as part of national governance framework. So framework. So we know that when we change the prime minister, everything's still there. And we also have to strengthen the capacity and build the lacking capacity. And also, get all key stakeholders involved at the beginning. And the last one, what we always need to build the evaluation platform together with the implementation. So you know what we're doing and what is the successfulness that we want. Good. 5 minutes.
Thank you very much. Excellent. I think you were very much on time. Again, you tried to integrate very eloquently the very much complexities of building the system. I think maybe I'll go with one quick question, and then we will have it open for all of you. When it comes to data development and policy implementation, data production, policy development, and policy implementation, what kind of highlights or advice do you have for the audience on how best to move from data to policy implementation and monitoring?
Well, I don't want to say this, but I think it's about politicians. Okay. Well, sometimes it's happened. So like we are researchers, we are the routine workers from the government. We do things all in the order from our boss, right? So when we get the data, sometimes the data is stuck in the lab. Sometimes the data is stuck in the annual report. It never go anywhere. So what is very important that we have to bring that. I think the word is advocacy. Right? So we have to bring that to the government. And how? I can just give an example for Thailand. Okay, we have many meetings. Okay, and many people here, were in the meeting with me. So we raised that to the minister, to the high-rank people. At the beginning, they may not understand us, but eventually they will understand us. And the point is, Thailand is exporting countries. So we have to have the national AMR surveillance always. It's just to prove that we handle AMR with scientific way. So that's the first. Okay, first, make sure what is important in your country. And you bring that up and put that into your advocacy paper and deliver that to the high-rank people. It should be work. Okay, thank you.
Thank you very much. Thank you. I'd like to invite the panelists up to the stage, and if you can be ready with a few questions. I think we have 10 minutes or so. More? 30 minutes? 3 minutes? 3:30. Okay, they changed it. I'm sorry. No, it's okay. No, we wanted to squeeze you guys. Okay, let's see. First question over here. Can you please state your name and your passion about AMR in a very few words and your question, please?
Well, it's very easy. Roman Kozlov, Smolensk, yes. Russian Federation. My passion is we are basically WHO collaborating center on containment of AMR. Basically, we has been working in this field more than 30 years. So my question is probably to Sabiha and Professor Chuan. I mean, it's understandable that everybody is worried about the adding of antimicrobials to the feed for animals. It's understandable, for example, in the European Union, in my own country, there is very strict regulations on the use of antibiotics as growth promoters. But the question comes up to the concrete actions. What actions should you implement in the low and middle income countries, basically to show independent farmers and probably even the big producers that they shouldn't do it? Because it's understandable, if you add up antimicrobials to the, to the feed for animals, it will grow up faster, the weight will be high, etc., etc. So what real measures do work in low and middle income countries in this area? Thanks.
If before me, right? Okay, okay. I heard my name. Chuan Chun. Okay, so the question is about the antimicrobial growth promoters, right? So I think the good example will be again, from Thailand. Okay, right now Thailand has been we successful in banning the anti-AGP, in animals, especially food animals. Okay, I can say it's not that easy for us to come to this far. So, okay, I can see the person from the LD Department of Livestock Development, there was a trick, okay? Went back to 10 years ago. They launched first, okay? We didn't force them at the beginning. We just said okay, to use the antibiotic as a growth promoter is not good. It will affect your import, values and so forth, And then we just do the training, do little by little, and then later the DLD announced, okay, there will be this law come up in next 3 years, and in next 3 years, so you will have to stop this antibiotic growth promoter, and then later, after 3 years, that paper has become the law, so it's enforcement. And you know what? It's not that easy to do that because the stakeholders, the private company may not agree. So the trick of the LD again, okay, they bring those private companies to be together. Any law, any issues, there will be the representative from the private companies and stakeholders and all associations. So they will know all the steps, every step that the LD move, and then they will agree. So I think the key words here, build trust. Okay, whatever do you want to move, whatever to do enforcement, you build trust. Make them feel like we are not forcing them. We ask them for collaboration.
Thank you very much. Dr. Sabiha, you wanted to also...
Just a quick example of the One Health stewardship of colistin in South Africa. So when MCR1 was first discovered in China, everybody looked for it. And we found it in humans, in poultry, in public sector, in private sector, etc. And so a number of government institutions got together and revised regulations. So up to that point, we were using barrels, and I mean barrels of colistin as growth promoters in feed. And it was the Department of Agriculture, Forestry and Fisheries then, now a different name, the Department of Health, our Health Products Regulatory Agency, so a national regulatory agency, our Department of Trade and Industry, and all of these people came together and revised a number of regulations to ban the use of colistin as growth promoters, had guidelines for the veterinarians. The South African Veterinary Council came in terms of oversight of the practicing veterinarians, and it worked. We stopped, and we are hopefully seeing a decrease in colistin resistance across. But that's a regulatory one, and it assumes that the country has the enforcement capacity to be able to monitor people, farmers, veterinarians, etc., from doing the right thing. The other aspect is to almost make the economic case and the health case or the animal welfare case to show that this will work always better in the long term, but that's a bit difficult to do. And every time that you remove antimicrobials from food animal production systems, it means you have to put in really strong biosecurity, and that costs money. So it has to be incentivized, it has to be subsidized, and it's not an easy answer.
Thank you, Dr. Sabiha. We have one from the back. Yes.
Hi, good afternoon to everyone. My name is Corey Ford, Dr. Ford. I am from the beautiful island of Barbados. And my question or statement to you is I think that for all of you in the room, speaking from a high-income country with a low resource or for low middle-income countries, I just hope that we all learn from the COVID pandemic. My concern with AMR for low and middle-income countries is that they often do not have the capacity to identify organisms. And this is a huge challenge. And even if they do, there needs to also be a no-blame platform as well for people identifying organisms. We saw that in COVID for some extent. So my concern is Many of the countries are far ahead, but we should learn from COVID that if one country has a problem and they're not able to identify it, then certainly they can be spread. So I just want you to take that into consideration in your discourse.
Thank you very much for your comment. We have in the back, Hailey.
My name is Haile. I work with WHO and with a quadripartite. And my question is for the four panelists. If you could just summarize your understanding, what is integrated surveillance in the context of AMR, so that we can have some clarity what it means.
Okay, so for me, it's easy. I gave you 3 steps or 3 levels of integrated surveillance. So it's sector-specific and across sectors as well, the antimicrobial resistance and the antimicrobial use, to see how they are associated or correlated with each other. And we know that the biggest driver is antimicrobial use. However, we do know that other parameters will increase the spread of antimicrobial resistance. So other aspects like IPC and WASH, etc., play a role. So the integration of AMR, AMU, definitely, but also integration and triangulation across humans, animals, and the environment, because we are all focusing on AMR as a One Health issue, and we're saying that we can't only implement the interventions in humans, we have to do it simultaneously in animals, crops, and the environment. So that becomes very important as well. And for me personally, I think we need to integrate it into our systems so we don't always are in the lookout for money to make sure that the surveillance system persists or is sustainable. Thank you.
Thank you. I know there is no standard definition for integrated surveillance, but I think integration should be at all levels in each sector, and it's about AMR and AMU, and also about burden and impact of intervention. And all sectors within the country, whether it's safety, food safety, academic, private, health, agri, animal, and ideally there should be one hub for all this information, so this information can be a source for action and policies and legislation. Thank you.
Thank you. So in Canada, we are currently operating under integrated surveillances where we collect and analyze antimicrobial use and resistance information across different host species, bacterial species, antimicrobial classes, with consideration of both regional and temporal trends. Our policymakers have also asked for information on what are things or interventions that could be used to reduce antimicrobial use. So what are the drivers? So for our integrated surveillance on farm, we additionally collect information on biosecurity, vaccination status, nutrition, and housing. And we also add that into our integrated surveillance program. Thanks.
And for me, okay, when you talk about AMR and especially One Health, okay, what come to my mind is this word complicated and unified issue, complicated issue, and we need the complicated or comprehensive and unified collaboration to solve the issue. And also, I always tell my students that AMR is borderless. They can go anywhere in the world without the visa. For us to come here, we still need visa, but AMR can go anywhere. It can go to the human, animals, and environment. So that's, when we need to solve the issue, we really need collaboration. We just have to scope them. Of course, we cannot get rid of AMR, but we have to make them stay in the place that they are supposed to be, and then we can stay with them happily. Yeah.
Not sure we'll be happy, but that's okay.
I'm not sure though.
Thank you very much. No, great.
Yep.
Yes, here and then there. I apologize if I'm mixing the order, but that's what I'm seeing. Yes, please.
Yes, thank you. So my name is Mohammed Isa. I'm a medical student, the liaison officer for public health issues at the International Federation of Medical Student Associations. So I have 2 questions, so please bear with me. They will be fast, I promise. So the first question regarding the example that were mentioned. As I have seen, for example, Canada, they have been working on this since 2002, which is about like 20 years earlier, and still some countries at the moment have not done this progress till now. So in terms of this gap between maybe, if we can call it, although I don't like this terminology, between developed and developing countries or high, middle, and low income countries. So is this maybe the reason that, for example, the Muscat Manifesto that's present on the website does not have a commitment regarding integrated AMR surveillance? Because from my understanding, such documents, when they are adopted, or like the text or the language used, there is no commitment. It's just recalling that the surveillance or the integrated surveillance in terms of foodborne AMR is good. However, there's no commitment that countries will work on integrated AMR surveillance. So is the absence of resources and the absence of, I would say, the solidarity between the countries the reason for the lack of this commitment in the manifesto? That's the first question. And the second question is regarding the priorities. For example, when we speak about prioritizing AMR, which is definitely important, in many countries, there are several public health issues. How can we convince the stakeholders and decision makers that AMR should be among the priority list? And one final question, I'm sorry. The final question is, there is no mention, like, in terms of the best practices, which are actually best practices, and in terms of what I have heard from several stakeholders throughout the day, there was no mention much of civil society in terms of the role. There was mainly private sector, the health systems, etc. So as a part of the civil society and as a young individual who would like to be involved in tackling this issue, what's your call to action to us and how can we be involved in this? Thank you.
Wow, okay, we're gonna have to try to dissect the questions. I think your first question, if I may try to address it, and maybe if our colleagues from Oman or maybe Haile would also, I saw he stepped out for a minute. But the Muscat Manifesto actually was done specifically, I guess, with the, after putting it together, there was a virtual consultation. So I don't know whether you were part of the virtual consultation where over 100 countries actually attended. But I think the commitment to integrated surveillance is embedded within the commitment to national action plans. And the national action plans are quite comprehensive. And what we're doing, at least from the quadripartite and from my specific area within WHO on health, is how are we going to make these national action plans accounted for by the highest level at the government? And that is one of our biggest issues. And because AMR, we have to understand, and most of us here are very aware, AMR is as close to the climate change when it comes to its complexity. However, one thing like I like to differentiate between AMR and climate change, at least climate change has the 1.5 degrees. In AMR, we don't even have that, right? We want to reduce use, we want to reduce increasing resistance, we want to improve IP. There's so many targets that we have, and I think one of our speakers eloquently spoke about the SDG targets. So I think the reason why this session was specifically made for this meeting, which is more of a political meeting, kind of answering one of your second or third question, this was really meant to be a political meeting, and we had launched the AMR partnership platform, and the head of FAO mentioned that. There is plenty of room for civil society and other partners to partner with us, but because AMR was such a complex entity, we're starting step by step. We've unified the 4 organizations. We created a 5-year work plan, a 5-year strategic plan, a 2-year work plan, but we will not succeed in this agenda, exactly as you said, and it's so refreshing to see a young professional as yourself speaking passionately about this, and I want to congratulate you for that. So I think I tackled as much as I can. If anybody wants to, I hope I didn't miss anything, but if I missed.
I agree with you, Dr. Hanan. The mandate of the surveillance was embedded in the manifesto by committing to the National Action Plan and also by adapting the 3 targets that are listed in the manifesto. So without having a surveillance, you cannot accomplish or attain to the targets.
Yeah, I fully agree to all these answers. Regarding your question about prioritization, I think when you look at the publication that has only recently been launched about the burden of disease, I think the burden of disease, this methodology makes it more easy to compare the burden of particular diseases. And this is exactly why it was set up some 20 years ago, because we are all mixed up with numbers. So and so many people die of, or so and so many people suffer from. But if you have one statistical method that you can compare it, it makes it much easier to put it in the focus.
Thank you very much. We have one there, and then there's one before you. So 1, 2, 3.
Yeah, hi, I'm Amit from Center for Science and Environment in India. So Haley talked about a very fundamental question. What is integrated surveillance? I want to take a step further before actually. To everyone in the group, specifically Professor Lothar, do we really need integrated surveillance? And I say this because to me, it's been 10 years now in this space. It appears that it has become something like a perfect is the enemy of the good, something like that. It is too resource intensive in my view that it is pulling down other aspects of the AMR containment. And I come from an LMIC and I have worked in Africa also, so I'm pretty sensitive to the idea of integrated surveillance. So my question is very simple, do we really need integrated surveillance? And if yes, and I do agree that yes, we need to some extent, then we need to make the case of integrated surveillance much stronger than really figuring out how to go about it. First, we need to make the case, because when we go to policymakers in different parts of the world, what we understand from them is, we'll do it, but why? Let us do it in our sector. We have to understand that there's a clear merit in the human health sector to do this. Animal health sector folks, particularly coming from the food animal sector, even if they do it, they do not disclose the data because of the trade issues. Environmental sector folks largely have very limited clue, the national level stake regulators. So what we are talking about is something which is very far-fetched in my view. It's been 10 years. I still see many more years for us to really be able to do that. So if yes, we are going to do it, then perhaps we need to make the case much stronger. And yes, we have to, I understand the stepwise approach, that's very well, but still people need to be told, is there a merit in integrating all the surveillance rather than just first doing it in your sector and trying to derive some meaning out of it? Thank you.
So save the tough ones for me. Just to say, I hear what you're saying, and that we have to think about making the health case as well as the economic case for integrated surveillance. When we speak about the health case, we think about, I mean, when we consider COVID and the word pandemic, it's very well understood by lots of people. And if you, I don't want to say silent pandemic, but AMR is a pandemic, and it is far more further reaching than COVID ever was. So it affects our health, human health, animal health, plant health, and environmental health. It affects our food systems and our food security and all of that. So, you know, on a theoretical and a scientific level, I can make a case for it. But we still have to give irrefutable evidence from scientific research in terms of transmission dynamics, so where and how it is transmitted, and so there's a real problem. And also we have to look at the risk. So what is the risk of environmental AMR to humans and animals, and vice versa? So making that case is going to be very important. The second aspect of it is making the economic case for it. So if we have to know where the problems are to be able to address them. And if we're looking at the transmission and interlinkages, etc., we have to undertake integrated surveillance to do that. The investment in it, or investment in surveillance of any kind, whether we use it for integrated analytics, etc., is also very important, because without surveillance, we don't know what to do and how to act. So it becomes really important for us to be able to do that. So the costs of the return on investment of surveillance needs to be made. So we have to make the economic case as well as the health case. I know I'm not answering you really well. It can be a yes or no answer. So anybody else want to take it? Yeah?
It's a really good question. And I would say absolutely integrated surveillance is needed. If we hadn't put that picture together of the poultry data with the human data, the poultry industry never would have taken action to reduce the preventive use of that antimicrobial class. However, even at the time, it was 2003 when we put that data out, our system was far from perfect. So it's important, if the system isn't perfect, just to clearly explain the strengths and the limitations to the data. And you saw from 2005 to 2007, the poultry industry started to resume rotational use of that antimicrobial. They weren't sure at the time that, you know, was this truly the situation, or could they control it with not complete return to use? So having the integrated data was able to show that by mapping what we saw at multiple stages in the food chain, from healthy chickens on farm to what we saw in healthy animals at slaughter, grocery store meat, and to people. Thanks.
May I add something? Sure. Thank you. I want to add just one other thing on integrated surveillance. If we look at the word integrated surveillance, and when we listen to the stories of the modalities of it, it's not one entity. It's so many different ways of integrating. I think the COVID response taught us that if we did not have that surveillance, continued surveillance, we would not know what is going on in a rapidly evolving pathogen evolution. The thing is with bacteria is that it's happening all the time, and we don't have our finger on it. I totally agree with you, and I'm really intrigued by you saying, if it is, and you know we're going to say yes, then we need to make a bigger case for it. And I think that's what we need to move forward to. And I think the Oman conference here, this is only our third. So AMR is really, from the political perspective, it's still quite in its early stages. And I think that we are here together because of a lot of work that was done by many people in the past 2 decades. And now it's time for us to push it further. So thank you for the question and for the nudge. I think we have one question here. Lothar, did you want to say something? Or I can get, okay. Because you had your hand raised. Please go ahead.
Thank you, Annan. Joachim Larsson, Sweden. I've been working with the environmental dimensions of antibiotic resistance for the past couple of decades. And I'd just like to make a clarifying comment to the value of environmental surveillance here. And I think we need to realize that we do environmental surveillance to fulfill several very distinct objectives. One obvious objective is to assess the spread of resistance to the environment. Basically, in the long run, what are the exposure risks through various routes, for example, through water, through soil, etc. So that's one obvious objective. Another very different objective is more backward-looking, similar to what we do with COVID surveillance. We measure, particularly in sewage, resistant bacteria to get a reflection of the carriage in the population that is contributing to it. And that is super attractive because basically with one sample you can get bacteria from 100,000 people. And it's particularly attractive in resource-low settings, where even if we have glass, it will take a long time until there are resources in many countries to actually fill that. But through a sewage sample, you can actually tell a lot about the resistance situations in the populations. What I think is, for that particular objective, you need to benchmark it against clinical surveillance so that it can be used and possibly even be used to, in the best of cases, to guide empirical treatment. Because in some parts of the world, the doctor has nothing to go on except his or her own experience in the lack of surveillance data. That's the core of clinical surveillance, is to guide the doctor in his or her choices. And maybe we can help that through environmental surveillance as well. There's also additional roles for surveillance, environmental surveillance, for example, finding hotspots for evolution of resistance, which most likely takes place in the environment to a large extent, which I'll talk about in the next session, so I'll skip that.
Thank you very much. I think we have a comment here, please. Sorry, there was Jamila first, but no, I'm sorry, I apologize. We will go after that to Dr. Jamila.
Thank you very much. I'm Dr. Waham Bright, Minister from Uganda. I want to say that integrated approach may work, but will differ from country to country because of overlap of mandates. But I think what we need to adopt now that we are dealing with this problem at a global level, it must be taken over by UN so that all of us do set standards to deal with the problem. Because what is going to happen is that even now, some countries are doing integrated approach. We are doing one health approach system, but others, the level of effectiveness is still not at par. And I think one of the recommendations we must speak from this meeting is that it must go high on the agenda at international level. Thank you.
Thank you very much. Dr. Jamila?
Thank you so much. Thank you. Actually, I have a comment, question, and a request, if it can be done. So it will be quickly. First, regarding comment, really beautiful presentation, amazing. And that's just give us that it's doable, it's best practice, but you know, having 4 countries or even 14 or 40 is not enough to change what we are talking about AMR. It will be really nice to how much we can learn from that experience in each country. And as we saw that each country did their homework, so each country really has to take it and take the responsibility and make it happen. It's doable, but needs a lot of effort. So that comes to the question, so what do you think as, you know, an expert in the field? You know, getting out from this conference, this is the highest probably conference that can get for AMR. What do you think should be the outcome okay, from or recommendation from this conference, having the excellencies, the Minister of Health around and agriculture all on the same table, that we will be able to convert this example to a lot of centers, more places, more countries. And the request probably even integrated to it, the word integration, is that, you know, we saw 4 examples, beautiful examples. Can we really get together? Because, you know, I'm listening to you, and it's really very beautiful, and I'm learning from each presentation a clue or a lesson. So can we get together and probably can sit together and see, this is the lesson learned, this is what works, this is what does not work. Maybe it works in different country, but I think this is the experience that we have to convert it to guidelines, lessons, fruits to go out with it, and probably the audience can utilize it for the future. Thank you.
Thank you very much, Dr. Jamil. And I think that Prof. Lothar will maybe give some final conclusions. I see him writing because I'm not. I've been watching the hands. But I think maybe we can, if anybody would like to respond, but as a quick answer, I think we have two GLG members in the audience. I see Sally sitting in the back as well. But the advocacy at the higher level for governments to adopt their national AMR action plans. The problem with the national action plans, unlike the SDGs, the multi-sectoral committees are floating somewhere. They're not accountable to any higher body. And we were able, after a lot of efforts, to create those 2 SDG indicators. And during the IECG, which me and Sally were on that, we were trying to see whether there could be an SDG indicator for AMR. So the political will and support needs to be there. And that political will will help the amazing champions that, if I'm not wrong, I'm pretty sure that in every country there are a few passionate staff, veterinarians, healthcare providers that are passionate about AMR, but they need the support, and we need that, and that's why the focus on this meeting was mainly at the political level. But thank you, Dr. Jamila. I don't know if anybody else would like to address this.
Thank you, Dr. Jamila. I totally agree with your comments, and I think the only way to do it is by sharing information, networking, twinning. I know some countries, they don't have the capacities and capabilities, but they can reach out to other countries in their region. If in the sector itself, I mean in the same country, they can reach out to another lab or to another center to help them or guide them in conducting such surveillance. So within the country, within the region, and globally, we can work together. Twinning, collaboration is the key in this.
Yeah, thank you very much. I think this was a very rich discussion. I liked it a lot. Thanks for the wonderful panelists. And my takeoff here is I particularly like the question whether we need this integrated surveillance, because these are the questions we need to think about, why we need concepts. For me, a brief summary, it is, from my understanding, and COVID-19 showed it very, very nicely, you need information for action. And you need this information in a sound manner that you really can also put pressure on certain parties. You can bring parties on board. And without sound data, you cannot judge on any intervention. I mean, you need sound data. This is my first takeoff. And the second most important is, and this is the third one, I take it the last. The second is, it is doable in all different countries. It can be done. But I have to say, it's very, very slow. It's frustrating slow. We are talking about this for decades. Yeah? And I think many of us have said, this is the moment. Now let's go for it. It is too slow. We have to make more efforts here. We have to push for this more. And we can do this because we have enough examples that it really makes a difference. You all gave examples where it makes a difference. It makes an economic difference. It makes a health difference also in the animal sector. And the third issue here is, I think, when you said, for example, there are certain regulations or certain laws, frameworks that hinder, for example, a trade or so, we also have to think about regulatory frameworks. We have to think about legal frameworks. Make a clear case. legal frameworks are made by humans, by us. So basically, we should also sometimes think more how we could develop these legal frameworks. And I mean, COVID has pushed many things to an extreme that I personally would have never thought about that it could happen. So it is doable. And we have recognized that AMR is really a whole of society issue. And therefore, we should really push to boundaries. We need to do this. We need to have more advocacy. We need to have more financing. And I think you showed all that it's doable. People must do it. That's it, basically. We need the will, and we will make it.
Thank you very much, Prof, for the final conclusions, and thank you everybody for being so interested. And we all rely on each other to make AMR diminished, I hope. And I think with that, we would like to conclude our session, and you will find the conclusions of each of the parallel sessions summarized at the end of the conference. So thank you very much, and have a great day. We'd like to take a photo with the panelists.
universal health coverage and pandemic preparedness. We, the GLG, will be trying to put our feet firmly in all of those on behalf of everyone. We've got to inspire at every level, and we really must go forward. So today we're discussing how to build and maintain political engagement to 2024, and I hope long beyond, driving up national data on the burden of AMR, and looking also at that elephant in the room. I don't know whether I dare say that with the ties here, as elephants are so important to them, on how to ensure sustainable financing to underpin our actions. We want to hear from the World Bank about their grants and the new Financial Intermediary Fund, affectionately known as FIF, because that can help funding for AMR. How we can build on the new GRAM data, the burden of disease data, to strengthen the evidence base. And I hope we're going to have a look at the role that all countries can play in supporting the UN Multi-Partner Trust Fund for AMR. Without that, the quadripartite can hardly help countries out there. So now let me hand over to Montserrat to pick up with the panel.
Thank you, Damsali. And yes, I'm really happy today to be in this panel. And we're going to have a very nice conversations. It's going to be about 2 hours. And we will be introducing each one of our panelists. And after that, we will pose some questions. And then we can also open the floor for questions on the audience. So I would like to present our first, our first panelist is Dr. Suriya Wonkongkatep. He's a retired Deputy Permanent Secretary from the Ministry of Public Health in Thailand since 2016. He was with public health background and now plays consultancy role in various areas, including global health, public health, HIV/AIDS, and AMR, and is serving as Senior Advisor in National Committees on Antimicrobial Resistance. His role in AMR, among others, includes leading the adoption of the first National Strategic Plan on AMR, pushing a strong AMR advocacy at policy level, leveraging unprecedented multi-sectoral collaboration with animal and environment entities, engaging academic and private partners on AMR, and designing monitoring and evaluation framework, and leading the pilot project of integrated AMR management in hospitals. Dr. Suriya, please, you have the word.
Good afternoon. Thank you for introducing me. Thailand is not the elephant. If it is a leaning elephant because of the COVID. As I'm talking on the country context, so it means the political commitment inside the countries, what we have done, and what our achievement in brief. I will present. I will talk in 5 talking points. One is that we adopt the first national strategies plan from the 2017 to this year. So this year is last year's, and we prepare the new one. The existing of the first strategic plan include the 5 overarching targets. After that, we establish national committee on AMR with these key governance structures that is on One Health approach. So it means that all of the ministers, agriculture, environments, and agencies are sitting in the committees. I will elaborate it later. Second, the achievement against the target. We have a 5 target, of course. 2 targets have been achieved. This is the reducing of the microbial consumption in human by 15% against the 20% of the target. But this is a general of the antimicrobial. If the antibiotics, it is at 20%, so it's over the target. And also the animal is much achieved. That is 36% against the 30% of the consumption in animals. But in the other hand, the mortality, the human AMR mortality has not been reduced yet. I think because it is the factors in the hospitals, interdisciplinary collaboration in most of the hospitals, it is a challenge. And also the remains a public awareness and practice on AMR has not reached the target also. So this is like a half-half that we reach and not reach, frankly. The third point is the several ongoing key interventions, including our integrated MR surveillance is going. It's like in the last parallel session also talking this. We are also struggling on try to fix some ideas on the integration of the surveillance. It's not means that we centralize everything into one room and say, this room is an integrated centers. We just want to see like a dashboard, and this is from this sector, another from this sector, and to see what is together, explain what is the situation. Also, we are struggling on the supply side antimicrobial reclassification, that is to make the regulation for distributions. And also for the hospital, we started implementing what we call the integrated MR management in hospital, or we call IAM. So it means that inside the hospital, we don't want to see this is IPC, this is the lab surveillance, it is a stewardship under the ID physicians. So we want every integrated every sectors, departments in the hospital work together under the leadership of the hospital director. Then also in the animals, we also success in banning of the antimicrobial as growth promoters and regulating the antimicrobial prescription in food producing farm via the medical feeds that our colleagues in the Department of the Livestock also here. We also securing the scientific and technical counterparts in parallel of the national AMR with the WHO country coordinating strategies, which only Thailand with these kind of strategies. It means the WHO countries and the government together initiate the pool funding mechanisms. The WHO contribute around 20%. Many agencies in Thailand contribute around 80%. Not only the Ministry of Health, but many. So we use this pool funding as a source of the technical work for feeding to the National Committee of AMR. Then the last one, the last point I would like to, we are endorsing the final draft of the second National Action Plan, which just in the 2 days ago, it was endorsed by the National Committee on MR and will submit to the Cabinet for approval. In the second NAP, there will be a new target, the 6th target. The target of lowering the risk of AMR contamination in food chain and environment, which is new in this strategic plan. Then we will have highlight 11 strategic foresight. For instance, that is a challenge in the second National Action Plan. Developing the AMR surveillance and data generation in food chain and environment. Strengthening the governance mechanism and monitoring and evaluation framework in the committees. And extending the collaboration with the civil society organization, and also the stakeholders. And lastly, the enhancing the leaderships in the IAM model of the hospitals. That is briefly on the situation on the MI in Thailand. Thank you. Over to you.
Thank you, Dr. Suriya, for a very nice intervention. Maybe then I can pass the word to Dr. Pius Makaya. He's a veterinarian with a doctor in philosophy in veterinary microbiology, majoring in molecular epidemiology of salmonellosis in poultry. He's the director of the Department of Veterinary Technical Services, responsible for veterinary laboratory diagnostics, animal health research, veterinary public health, wildlife disease surveillance and management, and veterinary epidemiology and informatics. He's responsible for all government veterinary testing laboratories, including coordinating the National Veterinary Laboratory Network, composed of both private and government veterinary laboratories in Zimbabwe. Please, Dr. Makaya, you have the floor.
Thank you very much. Your Excellencies and colleagues here, Zimbabwe is just as good as any other low and medium income country. We signed, the 3 ministers of Zimbabwe signed the National Action Plan. But after signing, there was this need for implementation of the National Action Plan. That's when the politics arose when we started implementing the plan. All funds were through the Ministry of Health, and the other sectors were not really happy about that, and we went into a sort of an evolutionary, or we had to really to change the structure, because we had already put in place a structure, but we really had to do it again to make it one health structure, and we are happy that we do have that structure now. Implementing the structure, we got really good support from the multi-partner trust fund, the Fleming Fund, and we really did well. That is what I think, that we, as a country, we did well. Especially from the Fleming Fund, we managed to renovate 12 regional laboratories from Ministry of Health and Agriculture, specifically from the animal health component. But I have to tell you, ladies and gentlemen, that I think only one lab from the environment was actually part of that operation. And when it comes to funding, I think it is one area we should go back and look into the national action plans and see that the strategies which are there are mainly to do with animal and human health. There is really need to revise that national action plan to include other sectors which were missing when we developed that plan. We also got an opportunity to establish 2 labs and upgrade them to level 3, biosecurity level, biosafety level 3. That is one from the animal health sector and one from the human health sector. And I think that was very good for us. But in Zimbabwe, we are trying to decentralize the laboratory infrastructure to provinces or regions, because most of the diseases, without the laboratory support, if an animal is sick or the temperature goes up, the farmer or even the veterinarian just goes and look for the next antibiotic. And in Zimbabwe, tetracyclines, the tetracyclines are quite available almost everywhere. So the diagnosis is not done in most cases, and people just inject the antibiotics. And when we realized that 65% of our casual deaths in Zimbabwe are caused by tick-borne diseases, which are mainly heart water, babesiosis, anaplasmosis, and theileriosis, which we call January disease in Zimbabwe. We really we approached the multi-partner trust fund to get some funding to produce vaccine for theileriosis. We believe that the best way of avoiding or reducing the use of antibiotics, since I've already told you that the diagnostic process might be a problem and all that, we think that it's better to try to replace the use of antibiotics by vaccines. So that was one of the efforts to replace the use of tetracyclines in treating tick-borne diseases, especially theileriosis, because from 2017 to the present day, we lost a lot of cattle. As you remember, more than 400,000 cattle died because of theileriosis. So we got funding from the multi-partner trust fund, and we managed to produce the theileriosis vaccine. Yesterday, actually, I got some photos. Our people are busy vaccinating for the first time. The field trial, not a trial now, but it's a field pilot vaccination program going on in Zimbabwe as we talk now. All that was to try to reduce the use of tetracyclines in Zimbabwe. And we are very grateful on that, that we have done that. Also, in Zimbabwe, we find that when it comes to funding, we think that we should focus really on training people, we adopt new technologies of diagnostics, decentralizing the diagnostic process to all nearer to the farmer, so that we reduce that temptation of just using antibiotics without diagnostics and microbial resistance testing. I think in brief, that is what we are doing in Zimbabwe. Thank you very much. Thank you.
Thank you very much, Dr. Makaya, for sharing that great experience on using vaccines as a tool for replacement of antibiotics. And now I would like to hand the floor to Mr. Isam. Sorry, no. To Mr. Saleh, the chairman of the board of Amma Poultry here in Oman. He is the chief executive officer at Oman Food Investment Holding Company. It's Oman's leading state-owned food security company mandated to develop food security projects for Oman. He's holding a company, Nitash, is a holding company active in agri-food in the area of dairy, poultry, red meat, flour milling, feed production, and horticulture. Mr. Al-Shafari is also working very closely with young entrepreneurs and through rigorous coaching and mentoring program, as well as supporting various circular economy and ecotourism innovations. Please, Mr. Saleh.
Thank you very much. Assalamu alaikum wa rahmatullah. Thank you. Welcome all to Oman. Thank you very much all for choosing to be here. A little bit, just maybe modify the introduction a little bit. Until last month, I was the CEO of the group. Today, I'm a board advisor. Given my age and experience, I have done 37 years of agribusiness, so I'm more of an agribusiness side by developing so many businesses in the food sector, including poultry, by the way. So I developed the first poultry project here. Today, it produces 45 million chicken every year. Okay, that's big number, and we're developing another project which is another 60 million birds per year. So this is big. Besides, I have done more poultry projects outside Oman. But yes, we, if you go to the market, get your coffee outside, the milk, the dairy, the cream that is in your coffee today or your latte was developed by us, a local dairy company, and so on. So I would dwell more into the agribusiness side, because when we do agribusiness, which is food security, by the way, we need a lot of biosecurity. Besides money, by the way, but we heavily invest in biosecurity. In biosecurity, it takes a lot of efforts, processes, protocol, and training for the people. And that's how we really prevent an outbreak of diseases within the premises, where you have, like, in a given time, maybe 8 million birds. And you know what will happen if you have an infection there, okay? So a big loss for us would be like $20, $30 million loss in one go. Therefore, while I was a chairman of the company, they never allowed me into certain sections of and no political figure can get in, by the way. That's how this was done like 23, 24 years, and it still is the case, whereby we never allow anybody who have any contact with farming or with workers or who have birds in his house to come close to the farm. Very tough, very stringent, but it works. It shows the example of how we can really invest proper money into training, into biosecurity, into protocols development, into disinfection and so on, before resorting to the use of antibiotics. Yeah? So it can be done in the agribusiness real world. We're business people, by the way, although I do a lot of advisory now today for countries and for companies and for those who want to set up their agri investment, so on, and I'm ready to work with any one of you to help developing these systems and protocols. But at the same time, we have to understand it has a cost. So when we develop feasibility studies for these projects, we have to embed and consider an investment that would go to biosecurity, that would go to training the right people, that would go to investing in the infrastructure that will help us prevent diseases, and resorting to antibiotics and to chemicals, harmful chemicals as a way to prevent disease. That should be the last resort. When I say the last resort, it means that it has to be minimal and seldomly used. Therefore, today, if you go to any fresh product in Oman, say meat, fish, poultry, you would notice that we are more competitive in terms of quality, in terms of residues, in terms of taste, in terms of freshness. And that's how Oman have really today made it to be one of the leading globally renowned countries that have attained. We are the 35th in a global food security index in the world in terms of our ability to be in the helm, in the largest group or the best group of those countries who have attained food security. That is investment. And we have been the first in the world for a cumulative growth of rate in attaining food security. We, in the last 10 years, since we started the company, coincidentally, we have attained around 13.5 points in the food security index. Quite a very silent sort of proudly announced, ranking and figures. But that has taken a lot of investment. So when we talk about investment, it's not only funding for research, which I really fully support. It's not only academic work that may stay in the shelves and may end up with professors and researchers getting promoted, to a professorship status, which is something they deserve. But for us in the agribusiness, it means money, it means bottom line, it means profitability, that it means trust of our end users and their safety, or the families and the consumers, as well as our workers. Thank you.
Thank you so much for that message, and using again a very great example of using biosecurity as another tool that we can have and we can reach out as a substitute or actually a prevention of use of antibiotics, and the message that we need to invest. And there are tools that we can do, but of course they need investment. So thank you for that. And I would like to now hand the floor, and I'm sorry, to Mr. Saleh Al-Shamfari. Sorry, to Dr. Isam Abu Salmen. He's the Regional Director of the Gulf Cooperation Council countries for the World Bank. He is based in Riyadh, the Kingdom of Saudi Arabia, and he oversees the bank's portfolio of reimbursable advisory services for the GCC, through which the World Bank engages in a strategic policy dialogue and provides technical assistance and capacity development, sharing its global knowledge and experience. He has more than 25 years of experience with the World Bank in the strategic areas of country management, corporate finance, and international capital market. The floor is yours.
Thank you, Montserrat. It's always a great pleasure to be in Oman, and I hope that you'll enjoy also your stay besides being in this conference, which is extremely important. And thank you for the organization also of this conference, which comes at a time while we are still in the pandemic, actually, of COVID-19. It doesn't look like when I look around this room, but there are still people basically getting infected and people also being dying. So, and that's remind us of the AMR and why it's important. We have seen the devastation that came from the pandemic. So we have epidemics and pandemics that are all over the place. They're accelerating and they're growing in numbers. So for us, basically looking back just the last 3 years to see that more than 100 million people have been pushed into poverty. We have seen basically devastation of economy, of society, and of some countries basically falling into recession and not being able to provide jobs and people losing their jobs and so on. It shows us how important the AMR is as part of this global preparedness. So I want to leave you with two things that I would talk about. One is the prevention part, which is extremely important. And the second is the monitoring of outbreaks. And our study back in 2017, and we'll ask the organizers to put it on the website if you are interested, shows that the economic cost of AMR in the best case scenario would be around 1.1% of GDP if nothing is being done to deal with AMR, and that's a global GDP. In the worst case scenarios, it would be, this is on annual basis, it will be around 3.8% of annual global GDP. Just to give you an idea, this is between $1.1 trillion starting 2030 and moving forward to $3.8 trillion annually in loss just on the economic side. So why prevention is important? Because prevention doesn't cost much in terms of funding. It is a very small amount of money globally, which is probably close to $10 billion. But prevention is not about the cost only, the funding cost. Prevention is very difficult because it needs a lot of coordination within governments. I mean, we're talking about different sectors: health, water, sanitation, food, agriculture, environment, transport, commerce, education. So these are like the importance of that coordination. So when we move basically to the prevention part, which is very small amount of investment in terms of money, it needs a lot of coordination and communication. And every country has to do it. And if we want to avoid what we have seen with COVID-19, some outbreaks that goes out of control and then basically it gets a huge amount of global devastation around the world. So that's the prevention part of what we have seen. On the monitoring, then it's very important. So the prevention is to reduce the risk of outbreak. But can we prevent? Can we have a 0% outbreak in the world? I mean, all the scientists tell us no. However, if we have the right monitoring that is transparent, quick, and can take action immediately, we can reduce the damage that comes from those outbreaks. So two things are important: prevention and monitoring. If you get out those two, then we are like in good shape, and we are basically in a way moving, and hopefully we have learned lessons from COVID-19 at the global level. We will be moving hopefully into shifting the paradigm from, okay, let's get things done the way that they have been done in the past, into moving into what we will be talking about, the One Health approach that will be very important globally. Thank you.
Thank you so much. I appreciate especially the message where we, if we can base and we can shift the paradigm to prevention and monitoring, we will certainly have very good effects on our AMR war. So thank you so much. I will now hand the floor to our last panelist, is Ms. Holly Reiner-Jones. She's the head of the Fleming Fund since November 2021. Previously to this, she was the deputy head of the team that and led on grants with multilateral agencies, as well as overseeing the independent evaluation of the program. Holly has a background in operational management and previously led an innovative mental health program in East London, and she has experience working in central and local government and in charity sector. She's the Fleming Fund, and you've already seen the great effects that they are actually doing with the examples of Dr. Macaya, and they are really good supporters for our war on AMR. So please, Ms. Holly, go ahead.
Thank you very much. And yeah, as Montserrat said, I will be speaking on behalf of the Fleming Fund as an AMR program, rather than from the perspective of a national government like my colleagues here from Thailand and Zimbabwe. So from our experience of delivering the UK government-funded Fleming Fund over the last 5 years and working with over 20 countries in Africa and Asia, really to support them to strengthen their national surveillance systems, but also importantly to generate, analyze, and increasingly to actually use data. And when we talk about data, we mean AMR data, but also consumption, use, burden data, and economic data increasingly. Using this data to actually change policy and practice, that's what we're all about. But through that experience, we've really identified 3 key challenges to securing political commitment to actually address AMR. And these are the challenge of just quantifying and surfacing the problem. That's, a first challenge that I think we're still facing, even after all this work and after all these years. A second challenge around the need for actually developing relevant, high-impact policies that respond to that data. And then there's also a challenge around the need to create political will and actually incentivize political leaders to enact these policies. So those are the 3 challenges that I just want to speak about briefly now. So the first challenge that I mentioned, just kind of quantifying and surfacing the problem, the historical lack of kind of One Health data on AMR has prevented us from really understanding the scale and level of the priority that it should have. There are lots of challenges that we face in the world. Where should AMR kind of rank on that scale? And I think everyone here in the room and at this conference sees it as being very important, but that can sometimes be a kind of hard message to sell. So I think what we have been trying to do in the Fleming Fund is really work in partnerships with many, and including projects like GRAM, to change this. So there are still major gaps in surveillance capability and data, particularly in animal health, but we've obviously mentioned environment, plant health, and other areas. I think there's a real need to kind of produce and use data that will enable us to understand the problem in different ways and to engage different communities. I think it's been said many times today that AMR is complex. There are many different stakeholders. We need to have different messages around that and actually to look at the problem through different lenses. So I think one of those is a food security lens, which will really help us to understand the impact on the 1.3 billion people working in food production and exports. Also need to look at this through an economic lens, and the World Bank and obviously colleagues have just mentioned, there's the projection of the economic cost of AMR reaching 3.4 trillion by 2050, and I know there'll be more information about that on the website, so you can kind of check those figures. We also need to be considering the relevance of the Sustainable Development Goals, which again have been mentioned today, and note that 1 in 5 AMR deaths is related to a child under 5. And it's clear that we can't achieve those goals and really tackle premature mortality without actually addressing AMR. So finally, on these points and the different lenses, just needing to kind of access to antibiotics, I think that's really essential. That's an essential component of universal health coverage. There are too many people who still don't have access to antibiotics or are impacted by substandard and falsified medicines. So given the quantity and complexity of the data involved in AMR, I'd really highlight the need for an independent assessments of evidence. That is still needed, which is why I think we need the IACG recommendation for an independent panel to actually be delivered. I think it's been mentioned a few times, but I think that's incredibly important, particularly in the lead up to the high-level meeting in 2024. In a bid to support the quantification of the problem, and also in an attempt to make a bit of a shameless plug, and Sally's already done this, but I just think it's worth mentioning again that earlier this week the Fleming Fund helped launch a data visualization tool which quantifies the burden of AMR for every country. So these are the kind of tools that can be used to actually surface the problem and really understand the impact that it's having. It's created by IHME and the University of Oxford, and really gives a sense of the relative priority of AMR, and it can be found on our website, flemingfund.org. So just another plug there. Our second major challenge is the need for relevant high-impact policies. So at a global level, the quadripartite, many national governments who are kind of here today, and many other organizations have done a really fantastic job and made a fantastic start. But we know that more needs to be done globally and nationally to actually ensure that AMR policies are based on high quality data, and that they're integrated with broader pandemic preparedness thinking. I think that's really important. I'd like to highlight 3 opportunities here for kind of policy making. So I think firstly, we know from our program, from delivering the Fleming Fund, that many countries still need to improve their capacity to actually translate data and the complex kind of array of data into policy. That is really needed, and it's not an easy thing to do. And I think this does require engaging broader sections of government, but also expertise. I think secondly, we've seen that the use of targets within national action plans for AMR can help to drive and focus activity, and my colleague from Thailand and actually Zimbabwe have both mentioned some targets there and the good work that they've been able to do. But I think it's important that those targets should be well supported by evidence and also ideally catalytic. And then finally on that point, just we need policies that properly reflect the wealth of evidence on the cost of effectiveness of AMR interventions. I think that's something we've seen from the Fleming Fund we increasingly need to kind of focus on going forward. And the final challenge that I just wanted to talk about, and I'll be brief, is related to incentivizing leadership through the creation of political will. So to date, we've had kind of a top-down pressure from experts and global leaders, including Dame Sally here, but many others that have spoken today. And this, I think, needs to be really accompanied by a sort of consistent pressure from below as well. So by communities, clinicians, practitioners that are affected by drug resistance. And we really need to facilitate and enable civil society organizations to help incentivize action by policymakers. And again, I think that's something that's been mentioned. It was mentioned in the last session, but the need for civil society to really get involved. And also to frame the challenge as an economic and food security issue, as well as a health challenge. I think that's really important. Thank you.
Thank you, Holly. I really appreciate your intervention because, yes, we still have a lot to do. And I think we need to produce and use data for action, and this needs certainly to impact our policy. So thank you to all our panelists. Now I would like to hand the floor to Dansale. Please go ahead.
Thank you, Montserrat. I frequently get people saying to me, the Fleming Fund is doing the wrong thing. It ought to do other things. And I got the money out of our Chancellor of the Exchequer on the grounds it would be about data. So it doesn't change because data can drive thinking and action. So that's why it's as it is, and well done. So I'm going to ask one question of each of our panelists while all of you think about the questions you want to ask. I'll then open it up to all of you, and if by any chance you dry up, of course, I've got lots more questions to ask. So I'm going to start with Thailand again. Montserrat, can you pass yours down? Dr. Surya, yes. Your country has a National One Health Committee. How have you used this structure to channel the message to your head of state and to senior government level so that you advocate for AMR? Because actually I always hold up Thailand as an example of people who, you haven't solved all the problems, but you're steadily working through them together. It's impressive.
Thank you, Sally. I will talk in two perspectives. One is the governance structures perspective, and the other is experiential perspective. That is personal, right? The first, the structure is that the National Committee is started as a supreme governing body on AMRs. So is, of course, is One Health is composed of like a senior management leaders among the different public agencies, academias, civil societies, advisors, in the same platform. Yes, but of course this is so big, about 35 members. So it's not very easy to move in this kind of things. So we have 5 subcommittees responsible for each particular strategies on the national plan. So this 5, of course, is not really, it's not the integrated because it depends on the each strategies. Like the first one is on the integrated MR surveillance system. But of course, this is integrated because we want to make all the One Health platform. And as I mentioned, our view is not to make one command centers and every data flow into this room. It's impossible. So we want to make multiple centers and collaborating to each others and producing one report or review regularly for what happened. Not optimist for the very well managed data. What you have, you do it. Of course, second, we have animals subcommittees. And animal, they have to integrate it inside the agriculture, like terrestrial animals, aquacultures and plant, and also the food productions, and also private sectors. And of course, we have a subcommittee on the creating public awareness. But of course, this is a very difficult and tough job for that. We did not achieve so much. So this is an example of the try to move on the like in particular way. But at the lower ends, we have what we call the SCG or Strategic Coordinating Committee, which I informally lead this group to make everyone in the same page, One Health. So we work in a respect manners for each other's animals. We not like make a conflict. You do this and you have to do that. We do not use this approach. So this is the structures, right? Of course, in the others perspective, that is my experience. When you talk about the political commitment, it is not the technical perspective. Those are professionals, highly technical. They are iron fist. That the government have to do this, have to avoid that, have to accelerate this. We have no time to wait, something like that. Of course, I understand, but we have to understand both. The political level have so many priorities. They have their own agenda, even the health, agriculture, so many, right? They have to doing many things. MI is not, sometimes it's not all time the first priorities. Sometimes in 1 year, but in the many years they are dropped down. So we have to maintain the agenda in the compromising way or compromising manners. So I am act like mediators. So to understand each other and feeding some our colleagues from Funding Fund says, data is power. So we try to create our generation, the data and feeding what is now the situation and what we should priority our actions. we are not very optimist that we have to do everything in 5 years.
So I
That
think
is-
what you're saying is you're very pragmatic.
Yeah.
You listen to people. You're talking about perfection being the enemy of good enough, and we should move on with it. But I wanted to just check one thing with you. You said that your cabinet would sign off the NAP, yes?
Yes.
Right. I've had the cabinet discuss AMR once as AMR, and then every year it's on the security risk, so they do see it once a year. What other countries? Put up your hand if your cabinet has discussed AMR in any way. No, not seeing it as a security risk. So how do you get it onto your risk registers of security for your nation? We've got it on ours alongside flu pandemics and things, because that's something we can learn from you and the British. Great. If you pass that to Piers, next to you. So you gave us a wonderful story about how you've used the money very effectively been given. But let me ask you, what can the Quadripartite Organization, the Global Leaders Group and other stakeholders and funders do more to help low and middle income countries in a way that becomes sustainable? Because remember, grants usually stop at some point. Thank you, Piers.
Thank you, Sally. As I mentioned in my first presentation, that our national action plans are not really comprehensive in the understanding that some objectives and targets which are for environment, from plant health, and other sectors of One Health are not in our national action plan. So I think it's now a quadripartite and the Global Fund should really focus on those areas and try to make sure that the low and middle income countries implement their national action plans to the end, including those ones which are not in the national action plans. And also, I think that the more funding should also go to the technical aspects of training people, having, of course, expert support from the tripartite, and also to capacitate our laboratories, as I mentioned earlier on, decentralizing the laboratories, because in these countries, we find that there is only one lab or two, and the country will be so vast, so big, so that to use the real method, the formal methods of diagnostics and treatment and control might be a problem. So if those funds are channeled towards that will be a good idea. Also to establish, like in Zimbabwe, we don't have a One Health platform. We don't have, but we do have the AMR platform. So we, like in Zimbabwe, we're discussing to upgrade the AMR platform to be One Health and put it in a higher office, which is higher than the 3 ministries, so that the funding will be distributed equally, and also the politics will be better handled when this organization or unit is in the president's office or the prime minister's office. I think it will be more in a better position to handle the politics, the financial politics. And also that will help that unit, the One Health platform or the AMR platform at the moment, to have access to national financing, so that when we get funding from the Fleming Fund, for example, or from the development partners, it will be like complementing a budget line, which is really under the fiscus, the government fiscus, that will make it more sustainable. How? Then there are other issues which I think Fleming Fund can assist the process. Thank you very much.
Thank you very much, Isam. Saleh, I want a conversation with you, so I'm going to come back to you. Can you pass it on to Isam, who I'm going to ask the question of how effectively AMR multi-sectoral action can be integrated within the financing mechanisms globally and at country level. So how can we make it be integrated so that people can get some money to set their platforms and make things happen?
Yeah, thank you, Sally. You give me the easy question, I guess.
Yeah, just hand over the dosh and we'll all be happy.
Yes, it's definitely a multi-sectoral thing. It's as I mentioned before, the prevention is the key, and the preventive measures and action. And here, let me just congratulate actually the quadripartite of WHO, WOH, FAO, and also UNEP to come with this technical blueprint for almost every country to go ahead and implement it. So this is the blueprint, and we are committed basically to help country move into that direction. So if we look at what we have done in the World Bank over the last few years, our portfolio today has almost $2.3 billion in funding for projects related to either directly AMR itself in 35 countries or sensitive to AMR around the globe. We have also basically committed for low-income countries over the next 3 years to help at least 20 of them move into an AMR action plan and be able to get their preventive action and also a monitoring of the system. So let me give you a quick example of a project that we have done in Vietnam, so you see a little bit what I am talking about. So in Vietnam, we have financed a project that reached 151,000 livestock farmers. The key feature has been the implementation of good animal husbandry, which included better disease prevention and responsible use of antimicrobial. Over 23,000 household-based producers received technology and learned techniques to reduce negative environmental impact. 362 meat processing plants improved their waste treatment system, and 490 wet markets upgraded their facility to improve hygiene. So these are like one project in one country that we have financed. But the main thing is still with the country. They have to be able to have the system. They have to be able to coordinate along multi-sectoral way to do these things in the most effective and I would say the least cost possible for the country. Now, for us in the World Bank, this is a global public good. If every country has the prevention that works for AMR, basically they have probably the prevention that works for a lot of other pandemic and diseases. So when we talk about, and what I mentioned before about prevention and reducing that risk of AMR, it's this interdependency, between people, animals, and ecosystem. But that can help also beyond the AMR itself. It helps us basically prevent a lot of those pandemics that might happen into the future. And that's basically a global public good. That's not only good for one country. From an investment perspective, as I mentioned before, the return on this investment for prevention and monitoring is very, very high. But if every country is able to do that, we might be able to reduce the risk in the future of having pandemic that can be devastating globally.
Fantastic. So Sally, I think this is where you come in. I mean, I want to welcome you here because far too often we talk about what's happening in the food chain without bringing in the private sector who actually are responsible for it, for delivering it. So how did you make the case? Here you are producing between 45 million poultry in one intensive farming and 60 million coming in another. How did you make the case to your board?
Okay.
Because
That's
we failed to make the case enough to get the money we need.
Yeah, well, I mean, we start with the idea. I mean, this is something that we have learned maybe from you guys, from those people in academia, the researchers, and so on. But we're more humble in the sense that we say there are a lot of things that we don't know. So what we do, we invite the right people to help us to take our idea. You know, we use terminology that maybe really works in the ground. So ideation, incubation, maybe prototyping, and then commercialization. And then we end up with products. It's a journey that we have been doing it. We have to develop the case, show them examples. Sometimes we have to do a pilot project. Okay? So with the case of poultry is invented long time ago with, you know, Homo sapiens when they were here, and so many things, you know, have happened where animal husbandry have become part of culture. Thank you for the efforts in what you did in Asia. An example here, for example, in the south where I come from, this is about 1,000 kilometers away from here, totally different environment. It's more monsoon, more greener, you know, totally different. We have an open grazed lands, okay, with around 200,000 cattle. Believe it? It's like the countryside of England, you know, very similar, but in summertime, and it becomes drier and so on. But yes, we have native species, like in Zimbabwe, where, you know, animals are being grazed by local tribes and so on. Household is there. They have plenty of milk. And that milk was not really consumed the way it should be. There was no hygienic way of handling the milk and so on. They were just making local ghee, local cheese, and so on. We came with a project, got it funded by showing an example of how can we develop a pilot project through contract farming, through collective grassroots efforts that shows the benefit that would end up that local communities could convert something which is very costly to the farmers, something to be reversed to become very, very profitable. So we developed this milk collection system through a pilot project, showed it, cased it to the whole country, and now got it fully promoted through the whole community. Now we're building another 6 major collection centers, which will cover the whole cattle population of the south of Oman. That include camels, believe it. We have around 200,000 camels also that will produce high quality camel milk. That will help also in prevention so much other diseases. And then it improves the livelihood, financially speaking, and then health system of the animals and the people. This can be done by working very closely at a multi-sectoral level, bring finance, bring businesses, bring public and policy makers, work together, showcase a story, sell the story to everybody, work with the locals, because to work with tribal system, you know, that has been there for thousands of years is not easy. Then people should come and work very closely from the grassroots. So we brought a CEO from within the community. We trained everybody to do monitoring, testing for bacterial counts and so on. And now everybody has a credit card that at the end of the month, he will see money coming through his mobile system. Yeah? But you have to be realistic. You have to come to the grassroots. You have to showcase, because what I noticed since the morning, and I've been involved in this, very dear to my heart, AMR cause, is that it's all high level. It's all to do with politicians, academicians, physicians, healthcare systems, and so on. But at the end of the day, we are speaking to ourselves.
Business is not here. Maybe I'm the only guy from a business. Oh, yeah? Okay. And then where are the pharmacology? Where's the big pharma? I don't know. Anybody here from big pharma? Yeah? Anybody from big pharma? No one. Shame. Say, we need everyone to be together, you know, at the end of the day. Because, mind you, there is underuse in communities throughout the world where people do not even receive enough antibiotics for survival. We have undernutrition that kills people, 25,000 people every day. Yeah? Every day, according to, you know, World Food Program, are dying. Kids are dying because of less medicine, less food. And we have to address it in a holistic manner. So, collaborative way of looking into the whole issue would allow us to understand where we should intervene with the right medicines. Okay, we invest in the other alternative medicines. Here in this country, we have a lot of essential oils, believe it, that can come as a replacement for antibiotics. Okay, but we still need.
I'm going to ask you to leave it there because
stop
you're getting into different science, but terribly important. I thought we'd have a conversation, and I was going to ask you about small farmers. No, you've given us some of the answers. That's fantastic. I believe we can't solve these problems without actually working with business and the small farmers. It's much more difficult for them, but you've shown how you can do it. And I'm happy to tell you I had dinner with 10 major farmer people last week discussing it. But you have to come to the high-level meeting in New York in 2024 and bring industry, because you're a big part of the answer. So, Holly, what do you think, why do certain sectors have greater difficulty getting political commitment for AMR, national action plans, and why? How are we going to change that? I mean, here we are, business can do it, but what they're doing is doing it steadily by demonstration pilots and conversation. What do we have to do? What have you learned in the over 20 countries you've been in?
Yeah, I think a big part of this comes from the complexity of the problem, and you know, it's been said again and again today, but it's worth saying again. You know, it's complex from both a scientific but also a political perspective, and obviously there are many actors involved, and we've talked about the pharmaceutical industry, but also farmers, many others as well. But we shouldn't use that as an excuse for inaction. You know, it's complex, but we can still start somewhere. And I think we can't successfully address AMR if we don't adopt the One Health approach that we've all talked about, and having that underpinned by strong evidence at the global, regional, and national level. You know, I'm going to keep talking about strong evidence, data, surveillance, because that's what the Fleming Fund is all about. But I think from our experience, we've seen that in most countries there are increased challenges in securing that political commitment for AMR national action plans in the animal health, agriculture, aquaculture, plant health, environment sectors. You know, there's still more work to be done there. You know, we're not as far ahead as we've got with human health, and that's not completely surprising. I think, for example, if we look at consumption and the use of antibiotics, current global estimates of consumption and use in animal health are helpful, but they remain insufficiently granular. You know, we're still not getting that level of detail, and I think that is inhibiting national policy change. It's, you know, preventing, or, you know, it's not giving the strong enough drivers for politicians and others to actually to make change. I think to tackle this, we really need to invest in the animal health laboratories, in AMR surveillance systems to actually support data that can create actionable change and kind of insights. And I say animal health, but I mean the many other sectors outside of the kind of human health sector. I think we also need the right mix of incentives. So I think this speaks to some of the points mentioned, that, you know, for farmers to participate in surveillance, there are different incentives involved, and we need to recognise that and respond to that. And we need the capacity at the national level to actually translate AMR data and evidence into policy. I think the consensus is that quantifying the cost of AMR across sectors is going to be tough, but it's necessary. We have to do that. FAO noted that the spread of AMR will directly impact the livelihoods of 1.3 billion people that rely on livestock for their living, and over 20 million people who depend on aquaculture. So while we know that 1.3 million people, lots of figures coming out here, 1.3 million people's deaths are directly caused by AMR. We still don't know the burden in agriculture. I think that's still to be kind of got to the bottom of, and that's why we're working with WOA and also the Global Burden of Animal Disease Programme to actually take a look at that issue. I think a whole of government approach is essential for change, and that should include strong engagement with ministries of finance, as well as ministries of health, agriculture, aquaculture, etc., and also global institutions like the Global Leaders Group, like World Bank as well. But I think what we also need is a whole of society approach, and I think this speaks to Saleh's point just earlier, that we need to include a dialogue with industry, with the media, with farmers, and also consumers, and I think that's incredibly important, and I think that requires us to get out of our comfort zones, to talk to other people from other sectors, but that's really needed to overcome some of these political challenges.
Thank you. So now it's your turn. What do you want to ask this famous, important panel? Great. One over there, that's the next one, and then a third at the back, and then we'll see if we've got more time.
With the permission of my Health Minister, His Excellency, Dr. Qalandar, he's with me. With his permission, I have two questions, one from Abu Suleiman and a small question from Saleh. Before I go ahead, I would like to introduce myself. I'm a pathologist, and I do care of the labs and all these things, the culture and all these things. I'm from Afghanistan, and taking care of the labs and the director. The first question, before I go ahead, I just want to tell you that we have a very beautiful National Action Plan, and recently revised by our Health Ministry. And the problem is that it has never been implemented. For the last 25 years, as you know, the political situation of Afghanistan, you better know, all of you are aware of that. Recently, a very serious, actions and work has been done under the leadership of His Excellency, Dr. Qalandar. The issue is that, as you just mentioned, that two interventions there, you just mentioned, one is the prevention, the other one is monitoring, right? Prevention, we all know that. Prevention is better than cure. It's an outstanding thing, we know that, right? The second part, the monitoring, in case of Afghanistan, how would you see this monitoring? How would you implement that? A country where for the last 25 years, the antibiotic resistance is not a challenge anymore. It's a disaster now. The data which I'm going to share with you, you will be surprised and shocked to see that. Even the vancomycin resistance, the MRSAs and all these things are, is at a huge, numbers. You will not believe it, but I have the real data with me, with all these things. How would you describe this monitoring in case of Afghanistan? The second question from Saleh, that when are you going to come and implement your pilot project for poultry in Afghanistan? We cordially invite you to come and please help in that case.
I had a feeling it would be inspirational, yes. John.
Yeah, well, Dr. Saleh will go to Afghanistan soon, I guess. All right. Look, I don't have a... Yeah, we'll go together. Actually, we have a presence on the ground in Afghanistan. You're probably in touch with my colleagues over there. But let me take actually your question to answer what Sally has mentioned before. No? And ask me the question, and I did not answer her. So I'll answer you, and that will be an answer also for Sally about the financial intermediary fund. So with the WHO, the World Bank established the Financial Intermediary Fund for prevention, preparedness, and response. Okay, and that's actually to fund critical investment in the areas that you are looking at. And it is destined for low-income and middle-income countries. So every country has its own specificities. And you can't basically just say, okay, I'm going to monitor in Afghanistan the same way that Sally and others are monitoring it in the UK. It's very different. The landscape is different. The technology probably that exists in Afghanistan is very different than what you have in other countries. So it has to be, the monitoring has to be really at the local level. And this is where also this fund will help in designing what could be a good monitoring system for Afghanistan. So this has been established this year. The first meeting of the governing body of the fifth, the Financial Intermediary Fund, took place in September. And the call for proposal, and this is for everyone, is going to happen over the next few weeks. By the end of this year, early 2023. So please Google, if you want, the Financial Intermediary Fund. These are grant money, mainly, I mean, the low-income country will have probably priority over the middle-income country, but it's for both. It's not definitely for high-income country because they can finance themselves.
Good. And Saleh, you're going to say yes.
And I answered you.
You did. Thank you.
Well, thank you very much. Congratulations on at least you're able now to address the issues and maybe ask people like Abu Suleiman and others truly to help. I think with the question relating to my profession, where I come from, you know, my role today is to help countries, companies, communities who really want to develop food security programs through a collaborative method, i.e., we go to World Bank, for example, we go to Islamic Development Bank, we go to you know, organizations such as the Islamic Society for Food Security. This is you know, one of the organizations that help countries to design a food security strategy to start with. And this is what we did 10 years ago. We created a strategy. Throughout the strategy, we extracted projects. And with these projects, poultry is one, dairy is one, small farmers is one, you know, contract farming is one, and that's a way that you dissect the system, you dissect the need, you create what we call competitive and comparative ecosystem that pinpoints areas of intervention required. Maybe in areas, for example, in fruits, you produce enough fruits, you need to find a way to export them. But in areas where maybe proteins, maybe in areas where you have maybe a gap, you have to address them by working very closely with UN system, with ISDB system, with the likes of those. And there are plenty of them who are willing to come and work together. From my end, I am ready to exert my expertise, my know-how, the key learned throughout the last, say, 27 years, 37 years, where we have ranked very well in the food security sort of index. Shukran.
Thank you. I think we'll take one other question. Who had their hand up over there? We'll take the lady. Then we've had balanced gender at least.
Thank you. I would like to introduce myself first. So I'm Hajar Sedi. I am a youth representative. I am a veterinary student from Morocco, and I would like to thank UNEP for making it possible for us to come and attend this event. I am representing the International Veterinary Students Association, and I have a question for all of you. I believe that engaging youth in policy making plays a key role in making a positive change and moving towards making stronger and more inclusive communities. So I would like to ask you, in your opinion, what are the measures that should be implemented to ensure effective youth participation in policy making?
I'm so glad I asked you. This is the perfect last question because I always think we're doing it for your generation. So let's work our way down after Saleh this way. So we're starting with you, Pius, and then only a couple of lines, and then we'll go to Surya and Holly.
Thank you for the question, ma'am. In Zimbabwe, we do have what we call using the poultry farming as an example. We do have what we call lead farmers in every community, where we train, we have a farmer and we target the youth and women because they are the people who normally rear chickens. And we try to encourage them not to use antibiotics, but to use two things that that is improved biosecurity and the use of vaccines. That way, it's part of the awareness campaign within those communities. If they see those things happening, that approach, that strategy working for them, then the community will sort to adopt that. And it's good to know that the youth and the women are actually adopting that kind of approach. I think that is one way.
Thank you. Over to you, Surya.
Yes, so glad to hear the ideas from the next generation. So progressive. I have got a very short solution that prioritization is the key. So in every situation, even the worst scenario in limited resources, as in Afghanistan, you need prioritization. What is the most hot issues that you can be able to tackle? You cannot doing everything in a certain amount, a period of years. And how to do that, you need evidence. And not optimize the very full evidence as in the developed countries. You just roughly make a pictures. And of course, you take decision on what you have adequate at the moment. That is my answer. Thank you.
Thank you. Holly?
Thanks very much. Yeah, I think it's a great point, and I completely agree that the young people have a key role to play in tackling AMR. I think for the Fleming Fund, I just want to speak briefly about our program, because we have country grants that we've talked about in 21 countries at the moment. We have regional grants, but we also have a fellowship scheme. I think that's been incredibly important in involving young people in the countries where we work globally. So the fellowship scheme is a sort of mentoring scheme. It's an opportunity for young people that work in relevant sectors that are linked to AMR. So we've got veterinarians, pharmacists, and microbiologists, but a whole range, kind of data scientists, etc. And they're supported through the scheme, working with host institutions globally. And it's a great opportunity to kind of have training, to run projects across nationally, but also on a kind of global scale, to have exposure, and then to bring back learning, training to their national countries. So I think that's been an incredibly important part of what we're doing in the Fleming Fund. It was kind of started off being a relatively small aspect, and I think it's kind of increasing in importance. And I think a big part of that, a big part of the positives that we've seen is how many young people are involved in that. And I think this links to a point around sustainability, which I've generally bang on about, but I haven't really mentioned in kind of my interjections today. But sustainability is so important within AMR. You know, we know that this is a problem that isn't going to be tackled in the next 5 years, 10 years, 30 years. You know, this is an ongoing challenge, and really we do need young people to be involved to kind of continue that fight on, and engaging now, I think, will be incredibly important. So yeah, thank you. I think great question.
So one of the many purposes of this meeting is to start a road to this high-level meeting at the UN. I've already said I think Saleh should be there. I think we need the youth there. So we need to intentionally involve you, whether it is by having a special kind of day for youth before and then feeding that in with a few of you. But I call on the quadripartite to think about this and help us design something so youth is involved. Which brings me to the summary, because we're going to finish on time. I thought there were some fascinating things said. I loved the Thai idea about getting pooled funding from government, from multilaterals, from philanthropy. How can we do all of that? And the fact that they get cabinet to sign off their national action plan. I was really impressed in Zimbabwe, the multi-partner trust fund and Fleming Fund, how you've developed 12 laboratories, and about how you're producing locally vaccinations in order to protect from infection, to save antibiotics and save from AMR. Fantastic. World Bank, prevention's cheaper than cure, and you're putting some money into it. Great. Fleming Fund, thank you. And Saleh, yep, you can do it. So just come and teach us all stay inspirational. So I'm calling out the Multi-Partner Trust Fund and the Fleming Fund. Where's the dosh? We need more money for countries to help them do what they need to do and make their plans that are technical experts. We need to call on countries to engage with the World Bank country teams on AMR, demonstrating interest, pull, and applying for the money. We need the quadripartite to build on their already existing collaboration with global financing institutions, including the World Bank. We need countries to support the integration of AMR into that pandemic instrument, because that points out or highlights it is a pandemic, it is fairly silent, it is One Health, and it should help unlock some money if it's in there. And we need all countries to champion the Multi-Partner Trust Fund. And could some of you also give some money to it? It's a bit short of funds, and yet we keep hearing how really good it is. And finally, as I'm here on behalf of the GLG, I call on all of you to engage with the GLG Global Leaders Group by bringing your asks. We've got an ask from the young. Bring your asks to the GLG and let's test it and see if they can persuade others to do things for you. Thank you for such an interesting conversation. I think the panel's been wonderful. Thank you, Montserrat. Amit is our rapporteur, so we know he'll do a grand job, and thanks to all of you.
Thank you, everyone. I had to run for the...
Yeah, I know. That was why I finished